Hi, everyone. I'm Chantil Jeffreys, and I know most of you guys on this call. I don't know Keith and was curious as to where he's from. If you want to type that in the chat, that'd be interesting for all of us to know. But thank you for coming to this brief webcast to learn a little bit more about MASLD with versus MET-ALD. I'm at Gastro One. I'm a nurse practitioner. I've been at this practice for about 24 years. I do clinical research and clinical practice. So that's a little bit about me and my experience in this field. We all know that MASH and MET-ALD and ALD and all of these liver conditions are a growing problem. So it's important to be able to differentiate them from one another. So this is going to differentiate MASLD from MET-ALD. Maybe. And that's me. So if you want to scan the QR code, I'll give you a couple of minutes, and that will record your attendance for this meeting. Hopefully I've given everybody enough time. So we'll start out with our case here. This is Ashley. She's a 52-year-old female. She was referred to your office or to our office because she had an abdominal ultrasound that showed signs of steatosis and also hepatomegaly. She doesn't have any symptoms, which is common with a lot of our liver patients, and she's not complaining of anything. She is female, she's Caucasian, and of importance, her BMI is 29.4. So this is a little bit about her past medical history. You can see she has PCOS, hypertension, hyperlipidemia, which are some of the things, the medical history that we see along with MASLD. She drinks about 2 glasses of wine per day. On physical exam, you can feel her liver edge, but it's smooth and it's not tender. And she is on medications for cholesterol and for hypertension, and she's also on milk thistle. So a little bit more about Ashley. Her hypertension is not completely controlled because I know the new guidelines like 120/80, but it's pretty well controlled with her current medications. Again, her BMI is 29.4. I think it's important to note her height because hepatomegaly can be overread on an ultrasound when someone is really tall. Their normal liver size might not be within that normal range, but as you can see, she's my height, so she's not very tall. With her labs, we see some minor elevation of ALT, AST. Her alkaline phos is a little high according to our scales. I know everybody has a different scale across the country, but it's a little above the 121 range that we have here in the Memphis, Germantown area. She has a normal total bilirubin, but it's on the high side of normal. No evidence of thrombocytopenia. Her A1C looks pretty good. Her triglycerides are borderline at 185. So it's important to do a fibrosis assessment on our patients. And as you can see, the FibroScan looks at both the KPA, which is the liver stiffness, and the CAP score, which is the amount of fat in the liver. So you can see normal is in the green and the blue. Then you start going to the darker or the brighter colors of orange and then red. Our patient's right there in the moderate fibrosis area. So her score is consistent with F3. And you can see, the green areas for the CAP score. So that means they don't have significant steatosis. But as you go along on the scale, you'll see our patient's is in the severe steatosis range. She's above that 268. So now that we've discovered fat in her liver, and we can diagnose her with steatotic liver disease, now we want to kind of differentiate what is causing this steatosis in her liver. So you can look through the scales. There's the MASLD. There's MASLD with increased alcohol intake called MET-ALD. There's full-on alcohol-associated liver disease. And then we have other specific etiologies like drug-induced liver disease and things like Wilson's disease, the LALD, and miscellaneous causes like hepatitis C, malnutrition, and celiac disease. And on the far end, we have the cryptogenic steatotic liver disease. That means we don't really know exactly what's causing that. In some cases, that might be something that we used to call burnout NASH, where the NASH, the fat was not showing up as well, but there was still advanced fibrosis. But there are other reasons for that steatotic, cryptogenic steatotic liver disease. So an important thing to know in this particular talk, or this component of looking at liver disease, is to know about the alcohol. You know, people tell us all the time. I have people tell me all the time, oh, I only drink 1 or 2 drinks a day. And then when you ask them to kind of quantify that, it may be like 2 40-ounce cans of beer. And you can see here the equivalencies between the different alcohols. So a standard drink of alcohol is 14 grams. And each of these different alcohols in the different quantities have 14 grams of alcohol. That is 0.6 fluid ounces of pure alcohol. So as you see the beer, you can get 12 ounces of that, but then it goes down from there. You can, only 5 ounces of wine. And, I know a lot of people, they call their glass of wine is that big mug that they pour the whole bottle in. But you have to take into consideration the actual amount of wine or of alcohol they're drinking, and not just how many drinks a day that they're telling you. So there's key pathogenic mechanisms in dual etiology of MASLD and alcohol, increased alcohol intake. With NAFLD, we see insulin resistance and obesity, diabetes. We also see a sedentary lifestyle, and there could be some genetic susceptibility. When you add alcohol intake to that, then it does cause additional issues with impaired lipid handling. If you have, also, when you look down the screen here, you see the NAFLD related and ALD related disruptions can cause even further damage. They can cause inflammation, and that can accelerate fibrosis and lead to disease progression. So it's important to really take a good alcohol history on your patient, because they may have these dual factors driving their liver disease. So as you can see, I think the important thing here, is the fibrosis level, of course, which is the KPA of greater than 5. Then, their 5-year risk is pretty high, the risk of decompensation. When you have MASLD, MET-ALD, and ALD, then you see that progresses. The more that they drink alcohol, the bigger risk that they have for that 5-year decompensation progression. So the key point here is, there are a lot of factors that drive the liver disease, but alcohol, I've always said this, alcohol puts fuel on the flame. And if you have one chronic liver disease, you definitely don't want to add alcohol to the mix, because that obviously makes the risks a lot higher the more you drink. So, do we just trust our patients? Do we, do blood tests or urine tests, or what are the best ways to detect alcohol use? There are biomarkers. There's the questionnaire. Of course, you can do an audit C score. It's a pretty quick score to do. We do that in clinical research all the time. I don't do that in clinical practice because, handing somebody one more thing to fill out is kind of frustrating to them, since we've already had them fill out all their paperwork and then fill it out again and then do all these other forms. So that is one of the screens that you can do for patients, and it's a pretty accurate screen. You can also look at their CBC and see if the MCV is elevated. If it's greater than 100, that can indicate chronic alcohol use. The GGT will often be elevated when you have a person that's drinking significant alcohol. There are also these other tests. There's the urine ETG. That's ethyl glucuronoid. Oh, I looked that one up because it just has the abbreviations, and I'm like, I want to be able to say the whole word, and I still can't say it. So there we go. You can get a hair sample or a urine sample to determine alcohol use as well. It's important to know that moderate to excessive alcohol consumption is about 28.6% in patients with, they're going to call it MASLD, because that was the term when the studies were done. And 25% of patients with metabolic associated fatty liver disease. Those are the important points to note. And there's, good accuracy in doing the urine test or the hair test or the audit C score. They were all pretty accurate in determining someone's alcohol consumption. So there are some gaps in the assessment of MET-ALD. And you can see there's a nice little algorithm here that kind of goes through that. It's, evidence of metabolic dysfunction. So you want to look about the metabolic dysfunction in these patients for BMI greater than 25. The fasting serum glucose of greater than 100, the metabolic factors that we generally see in patients with MASLD. And then you want to look at maybe isolated hypertension or hypertriglyceridemia. If they don't have that, then they've got MASLD. If they do have that and no evidence of alcohol intake, then they've got MASLD. You can consider the PEth testing. A lot of people do that just to determine whether the patient is actually, being honest with their assessment of their alcohol use. And if that's undetected, then they've got MASLD. So you want to assess the alcohol use, the quantity, and not just the number of drinks, because, this drink is not the same as this drink. Their drinking patterns, is it daily? Have they ever had issues with binge drinking? Have they ever had to go to any kind of rehabilitation or Alcoholics Anonymous in order to stop drinking in the past? And then you can consider the PEth test if you have it available, which is approved on the market. So if the patient has alcohol use of if they're female and they have 140 to 350 grams in a week, or if they're male and they have 210 to 420 grams in a week, or if their PEth score is 25 to 200, then you can diagnose them with MET-ALD. If they have alcohol use that's greater than 350 or 420 with females and males respectively, or if their PEth score is greater than 200, then they should be considered to have alcohol-associated liver disease. You definitely want to exclude those differential diagnoses that we talked a little bit about up front. All right, so our patient, back to Ashley, she had a PEth score of 200 to or 20 to 200. Hers was 120. So she was in that moderate to excessive consumption or too heavy alcohol consumption. So she's right there in the middle. So we've assessed, her amount of alcohol, and we realize, we've concluded that she has 120 grams of alcohol per week. So a little bit more about the PEth score. The PEth score can sometimes give you a little false sense of the patient's chronic drinking habits. A PEth score has been detectable for 3 to 12 days after one single binge. So if the patient had a binge where they drank multiple drinks at one time, but don't drink any other time, that PEth score may be elevated as well. And this was comparing it to the number of alcohol units consumed per day with a digital diary. There was no significant variability by sex or by BMI, so that's good to know with the PEth score. So alcohol use in individuals with excessive weight. So a lot of our MASLD patients do have excessive weight. And this was a study that looked at patients. They screened 659 patients, 617 enrolled. They took out the non-drinkers or the ones with missing data. So they ended up with an N of 333. The females, if they consumed 140 to 350 grams of alcohol per week, there was 11 of those. And if they had more than 25 nanograms per milliliter, the PEth was more than 25 nanograms per milliliter. That was 21 of the patients. So the males, they had a different range with the same range for the PEth, but different range for the grams per week of the alcohol consumption. 97 of the patients were analyzed with suspected MET-ALD. And the important thing to realize is 15.7% of patients were at risk for MET-ALD of this study population. So other information about Ashley, she has a history of PCOS, hypertension, and hyperlipidemia. So what does that mean for our patient? Alcohol consumption and hypertension, there have been multiple randomized controlled studies involving the association between alcohol and hypertension. And they've seen a biphasic effect on blood pressure. So blood pressure may decrease for up to 12 hours after consuming alcohol, but then after 13 hours, it increases. So alcohol and hypertriglyceridemia. The mean plasma concentrations of over 10 hours after administering 2 standard drinks or water. So some patients got water, some patients got alcohol. And then they saw that these were the findings, which are a little convoluted, but I looked up the study so that I could give you more information. The important things to know on this one is there was a 37% decrease in mean plasma concentrations at 30 minutes, and that was the hypertension group that did have alcohol. So alcohol induced a 37% decrease in their mean plasma NEFA concentrations, which was 10% greater than the water-induced patients with hypertension. They also saw a reduction in the non-hypertensive patients that were given the alcohol of about 35%, whereas it was 8% for the water intake patients. So back to Ashley. We remember her case because we've talked about it this entire time. We know that, she's a female. She drinks, moderate amount of alcohol. She doesn't have any symptoms. She did have a F3 fibrosis on her FibroScan and severe steatosis with a CAP score of 310. Now we can diagnose her with MASLD. That's predominant MET-ALD. So given her alcohol intake, we can say it's predominantly the metabolic ALD, alcoholic liver disease. So what are current treatments available? Right now, we don't, we have diet. Mediterranean diet seems to be the most effective in not only cardiovascular disease, but also diabetes and in MASLD. We recommend exercise and weight loss. We've been doing that for decades. But now we do have one medication that's approved for MASH with F2 to 3 fibrosis. So she might be a candidate for that, even though she does have the alcohol compounding her MASLD. She does have the MASLD and she does have significant fibrosis. She's F3. So she might be a candidate for resmetirom. So what are your recommendations regarding the alcohol use? I haven't been a hard and fast stop alcohol completely, but in this case, with this patient, I would definitely tell her to stop alcohol completely because she has confounding factors and she's already F3 and we don't want her to advance any further. What about HCC screening? Does she need it? The answer is yes, because she's F3 fibrosis. So it doesn't matter if it's predominantly from alcohol or if it's predominantly from MASLD. She still needs the screening because she's F3. So the ideal metabolic ALD, MET-ALD definition for clinical trials is based on objective biomarkers this will overcome the underreporting of the alcohol use. It also standardizes the assessment of recent alcohol use, and it can certify alcohol abstinence. You want to ensure that the drivers of liver disease are present, more than one of the cardiometabolic risk factors, or the presence of hypertension and hyperlipidemia after stopping alcohol. And then consider exposure to risk factors. So fulfill these criteria during the last 6 to 12 months. So take-home messages. New definition for MET-ALD is alcohol beyond 140 to 350 grams per week for females and 200 to 420 grams per week for males. They need to meet the clinical criteria could be underestimated in MET-ALD and also alcoholic liver disease. The alcohol biomarkers like the PEth score are helpful. We want to reassess the metabolic dysfunction over time. So what happens to these patients once they stop their alcohol and the alcohol is removed? We want to reassess to see if their metabolic dysfunction has improved as well. And consider adequate exposure to risk factors. The criteria for clinical research should give us an objective MET-ALD diagnosis, and it should be compared among different sociocultural realities because, no one size fits all for every culture. If you would like to visit the GAP MASLD MASH community network for additional disease state education and Resdifra webcasts, you can scan this QR code and it'll take you straight there. I'll give you a couple minutes for that.